good, guys? It's your girl, Dr. Beauty, and I am on the way back from the hospital right now. So it wasn't too bad of a day. We have I have 2 more days left at this particular hospital, but basically, during this family medicine rotation at this hospital, we've been rounding with the residents and the attending physician, and today was a really good day. Usually we've been reporting at 6:30 because the night shift staff will let us know if there were any pertinent changes with the patients, and then we'll use that information to proceed with the day and make any necessary changes. We usually get this huge Google spreadsheet that enables us to see the major changes that happen with the patients, in terms of drugs that were administered, vital changes and all that. So it's a very great system. What else? Yeah, so today was a really good day. I really like the resident that I've been working with, and the main reason is he's very uplifting and he's very how do I say, he's non-traditional with his approach. He really actually cares about the patient. He's not just trying to treat the disease, he's trying to treat the patient, ensure that their well-being overall is improved, which I really like. Because sometimes when we round with about 20 students, so there'll be students just saying the patient blah 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 blah, and it's the patient's right there, so we want to bring back humanity to this field, right? So I really like that about my resident. And when I presented today, he and some other residents as well told me I did a good job. I was very confident and concise, which I'm always aiming for. I feel like I've improved immensely. It's not like I was horrible at presenting before, but I just didn't have that level of organization that really lets the doctor know, okay, what is your plan? What's your assessment? What is the chief complaint? Obviously chief complaint first, but so yeah, I have improved immensely. I've always been someone who's confident at public speaking. I was a TA in on the island for anatomy, and I was a TA for anatomy, and I was a tutor for neuro and physiology. So I love talking, as you can see from me making these videos. But yeah, we had some interesting cases today. One case that we had, this patient had a history of alpha-1 antitrypsin disease. So for anyone who doesn't know that condition, it's basically a condition that can lead to early emphysema. It's a hereditary condition. So these patients are missing an enzyme called alpha-1 antitrypsin, which breaks down elastase. So it can cause cirrhosis. It can also cause emphysema, because it breaks down the lung tissue and the liver tissue. So this patient had that. So she had a liver transplant in her past, but she was presenting with epigastric pain. She was kind of a little bit all over the place because she had epigastric pain and right upper quadrant pain that was radiating to the right shoulder and the back, and her troponin levels were super high. I don't have the exact number off the top of my head right now, but so obviously they were thinking, okay, this may be cardiac in origin, but her EKG didn't show any significant ST changes, so obviously it could be STEMI, which, STEMI, you do have elevated troponin. So now she was on the floor in the morning when I went to see her, but then she got transferred to ICU, and then when we got to ICU, we were informed that she's going to the cath lab at another facility. So it's pretty intense. They just want to take the precautionary methods to make sure that there's no blockage in the coronary arteries. Then another patient we had, they were suspecting either ITP or TTP. So these are conditions where you have thrombocytopenia, because in one case for ITP, you have these antiplatelet antibodies, which isn't necessarily the case for every patient, but in many patients they have platelet antibodies, which are consuming the platelets. So you have thrombocytopenia. You basically can't form clots. So you have these patients that are bleeding, and typically it's caused by infection, secondary to infection, but there can be many other etiologies. And then you've got TTP. So TTP is when you have a deficiency in the enzyme ADAMTS13. So if you remember from your physio, von Willebrand factor is a factor that helps platelets bind together. So if you don't have the enzyme that prevents platelet binding, you get excessive platelet formation and thrombosis. So this patient, oh yeah, and by the way, so usually there's a pentad of symptoms that these patients could present with. They may not present with all the symptoms, but usually there could be like neurologic symptoms. There could be end organ failure because of thrombosis of the arteries supplying these organs. But this patient came in with altered mental status. So that's why my resident that I was following thought that it could be more of TTP. But when they consulted with Hem-Onc, they were saying that they were leaning more towards ITP. So in both cases, you'll have thrombocytopenia. But so that is why, and it's very interesting because this patient had bilateral DVT in both the popliteal arteries, or sorry, not the arteries, the popliteal veins and femoral. So he is contraindicated for anticoagulation because he's thrombocytopenic. Okay, so that was an interesting case. So now he's on pain medication and he's getting an IVC filter today, so they're going to move him to tele. And then there was another patient. What did she have? Okay, so I talked about the alpha-1 antitrypsin. Oh yeah, C. diff. Okay, C. diff is like really common in this hospital that I work at, and I'm sure it's common in a lot of other hospitals. For example, if a patient's on long-term antibiotics, they could get C. diff because you're depleting the intestinal flora. So this patient had come in for, excessive diarrhea. She said that her son had diarrhea at home before she did, and they did a stool culture and it was positive for the C. diff antigen and toxin. So she definitely has C. diff. She's still having diarrhea, so you do not give any type of anti-diarrheal agents during C. diff because it can lead to toxic megacolon. So they are just letting her do her thing and giving her Flagyl, which is metronidazole, and vancomycin to cover for all those bugs. And obviously with diarrhea you want to watch the electrolytes. So her potassium was a little bit low today, so they are giving her potassium for that and managing her electrolytes, but particularly potassium, because if you've got any irregularities with that, can have cardiac symptoms. And I think there was one more. Yes, I had some very interesting cases this week. So there was a guy, he's like 46, he had perirectal abscess, and he got, I think this happened 4 days ago. So he was just having some rectal pain, like whenever he sits down it hurts. So they found out that he had a perirectal abscess, so they drained it yesterday. Interventional radiology came in and they placed a tube in to drain that bad boy, and there was like 80 mils of fluid, purulent fluid. I saw it in the bag. So, and obviously it was positive for gram-negative rods, which is most likely E. coli. So there was that. So now they're monitoring, making sure that he remains afebrile and does not have any leukocytosis. So his WBCs were good, but he had a Tmax today of 99.5. So they're, obviously trying to make sure that he doesn't get any more fevers. Oftentimes, obviously, the body temp increases with infection, but we don't want it to keep you know, fluctuating like that. But other than that, he's doing well. The only other comorbidity that he has is hypertension. So, you know, that's all good. But all of these patients were Spanish speaking. And like I said before, I'm brushing up on my Cuban dialect down here, so it's been very interesting. But they're very appreciative when you at least attempt to speak Spanish with them. Some of them, it's so funny. They know English. They just prefer to speak Spanish. I don't know. That's just how it is. So, yeah. That's pretty much all I have today. I think I sound a little bit better. I did have a cold last week, and I had the nastiest cough. So I feel like my voice is kind of like nasally and a little bit raspy now. There's definitely something going around the hospital. But yeah, so next week we're going to be at a different hospital. I heard that, you know, things may be a little bit different because it's different attending, obviously different style of teaching. We'll have like lectures and do practice questions, which I think is going to be really helpful for the shelf. But let me know if you guys want me to explain any of the conditions that I discussed in this video today, or any of the management techniques that were used, because that's basically what we're going over right now, is diagnosis, management, and treatment of these conditions. So also, yeah, I'm not going to be really traveling too much around because I'm going to be studying for my shelf. So things may be a little bit dry. I may just talk about what I'm doing every day at the hospital. But until, oh yeah, well, maybe I'll make a makeup tutorial soon. I'm trying to get a hold of the new Rihanna eyeshadows, so I may make a review or a tutorial on that. So anything you guys want to see, drop a comment below. And until next time, deuces.
Are you there? Baby, are you there? Right on this. Me girl, I've been looking for you